Okay.
I'll press it.
Okay, press.
Yes.
Okay. No, the
No,
voice.
you don't need to tape it.
That's we're voiceovering. Not too happy with that, but we are. Is that on there already?
Yeah.
Erase it.
We can start over.
Oh, no. Okay. Let's go. All right. Next slide.
Okay.
It's up there? Oh, okay. I'm looking there, but okay. Oh, we're going to get, this is an overview where soup gets whipped up, and it's part of our normal physiology, and that's something we learned evolutionary. Put your hand on that hot stove, you pull it back fast, okay? So what happens? You're flooded, and we'll see this as we talk about the gating process, that this whole physiological thing gets whipped up. Now, you're in surgery, they cut you, and for 1 hour, the physiological response is going full tilt. Then, anesthesia only keeps you asleep. That's all it does. You wake up in what we call wind up. It's completely out of control. And when it's completely out of control, it's very hard to manage, because even giving regular doses won't be enough to get it under control for a couple of hours. So what they're doing now, the big direction is preemptive analgesia, where they start giving the narcotic when they start the surgery, so that the patient does not wake up in wind-up. So that's very, very important. All right, let's talk about chronic pain. It's really caused by the disease itself, and you either have nerve compression, tissue invasion, metastases, and 25% of people in the United States have some kind of chronic pain. It no longer generates the fight or flight response, and it's very common in the following diseases: lupus, rheumatoid arthritis, sickle cell, fibromyalgia, low back pain, headaches, all of those things. Then there are particular protocols for how you handle each one, but just know that these, you can be sure these people are going to have chronic pain. Neuropathic pain. It's the most challenging of all chronic pains that we have, and it really results from some type of nerve injury. It can be central or peripheral. And because of neuroplasticity, we used to hear things like, how could he have pain in his leg? He severed his spinal cord. What you don't know when you say that is there's a plasticity, so that it's morphing and changing the way signals are being sent, so they truly can have pain, even though they might have a severed spinal cord. Okay. Now, the most common are the diabetic neuropathies. Post-herpetic neuralgia, we're seeing so much more of that now. That's why they're promoting the shingles vaccine, which may or may not be a smart thing. It's the jury's still out on that. But that is excruciating pain. And because we have more elderly people and we have more immunocompromised people, we have a greater increase in shingles pain. Could be radiculopathy, trigeminal neuralgia, where you'll have people that, the trigeminal nerve is across your face. You can't even open a door and let a breeze go by. They're in excruciating pain. Actually, I was sitting in a dentist's office waiting for my appointment, and a patient is in there. I could hear him describing trigeminal neuralgia, and he's saying, well, we'll look at that tooth, and I called him out. And I said, hey, listen, this sounds like trigeminal neuralgia. And he sent her off and got treated. So here he was trying to get rid of the tooth pain. He didn't understand it. Okay, back one. Yeah, otherwise I'll find it. The one before that. Okay, it arises from the nerves, either in the spinal cord or some other place in the CNS. It's poorly localized sometimes, but here are the key words. It's shooting, it's electric light, it's stabbing, shock like pins and needles. Those are the sensations that you will most commonly hear with this. Visceral pain is really body organ related. It's poorly localized, and it's deep, and it's cramping. So, for example, a ruptured ectopic pregnancy, you'll have pain on that shoulder, and it's poorly localized because if your shoulder really hurt, you could grab it and rub it, but with the visceral pain, you can't. You can't get your hand on it, but it is severe, okay? Somatic pain, it's deep somatic pain with bone or connective tissue, or superficial, like even a paper cut. Look how painful that little paper cut could be. So somatic pain could really generate from very local skin things. All right, now we're going to talk about the gait theory. Did you all read the chapter? They can't see you on this, so you can tell the truth. Okay. Do you understand it? I haven't seen any textbook that makes it easy. So today you will hear it and know it. Okay? All right, we're going to talk about different fibers, okay? A delta fibers. They're found in the skin and the muscle. They're myelinated, so they're wrapped nicely, right? So the transmission of an impulse can be fast and return. It's localized, and it's really what acute pain really generates. That's the transmission called nociception. That's the term meaning the process by which the injury goes along a line to be registered as pain. Okay, so when you see that fancy word, it just means pain transmission, nociception. Okay, so with A delta fibers, that's going to be your fast fibers letting you know right away this is acute pain. Now, there are A beta fibers, and they conduct non-noxious impulses. Okay, some of the non-noxious impulses could be pressure, crushing, those sort of things. Maybe not crushing, that sounds a little bit more like A delta. But other kinds of stimuli, such as pressure. Okay. Then we have C fibers, and they produce persistent, slow pain transmission. They're not wrapped too tightly. There's not much myelination, and they respond to thermal, chemical, and strong mechanical stimuli. Okay, but what we're going to talk, what I really want you to know is A. I'm going to give you a silly little mnemonic, okay? A delta. Remember delta dawn? It dawns on you that you have pain. A delta, okay? A beta, this is dumb, but you'll remember it. Better do something about it, okay? So remember that. So they're non-noxious, but we're going to be able to use them if you remember, better do something about it. And C fibers, those are the chronic, annoying, unmyelinated pains. Okay? Next. All right, here's the gating mechanism. It occurs in the spinal cord, and A and C nerve fibers transmit pain impulses from the periphery. And where do they go? They go to the dorsal horn of the spinal cord. Yeah. Now, special cells in the dorsal horn inhibit or facilitate pain transmission. So the impulse comes, they can inhibit or pass it along. Okay, stimulation of A delta and C fibers. Okay, A delta, it dawns on you, you have pain. And C fibers opens the gate. Did somebody say something? Okay, next. Stimulation of A beta fibers, beta, do something about it. They stimulate non-noxious impulses, and that closes the gate. Okay? A delta, strong message. And C, the annoying, undifferentiated kind of transmission. And then we have A beta, which is non-noxious. Okay? Next. All right, now here's the question. I can't read this too well, but you will. But anyway, let me just say this. Say one of you walks into this room, whacks your shins so hard against the desk. Now, aside from what you're going to say, what are you going to do right away? What are you doing? You're closing the gate because you just stimulated A beta fibers. That's what you have to know about gait.
So when you open it is when you hit your shin.
Yes, then the A delta's pouring through. What you want to do is jam that gate with something else. You'll close it by massage. Okay? Yeah, it's that gnawing, kind of undifferentiated, slow, unmyelinated stuff. We can handle that too, but I think it's critical to know that the gate opens with C or A delta, delta dawn, remember that, and closes with A beta, okay? And that's important. Why is massage so helpful sometimes? Why do you grab something intuitively, you know, to close the gate? Okay? Yep.
So that sore feeling, that achy feeling would be beta? Like after you hit it?
That's that.
Oh, that's C fiber.
Yeah. But you're going to close the gate now by rubbing that arm or leg, whatever it is. Okay? And that comes up as questions for, considering what massage as a treatment modality, what would you say that was effective for? And one of the multiple choice answers will be closing the gate. Okay? So does everybody understand the gate now? Okay. Go ahead. Okay, that was it. All right. Now, I'm not going to get into the second order neurons because I think it's more than you need to know, but at least you have that slide, okay? All right, and in the central nervous system processing, we have the thalamus, the midbrain, and the cortex. So it goes from the relay station to this cortex, and then the cortex interprets that signal as pain. This is in nanoseconds. Okay. All right, now I'm going to teach you a cartoon about the gate theory to make sure you really learned it. Whenever you have an injury, there's a neurochemical soup. Prostaglandins, bradykinin, serotonin, substance P, and histamine. That's just some of what's in that neurochemical soup. Immediately gets stirred up. Now we're going to come back to some of these when you'll see, for example, when we talk about nonsteroidals, we'll be looking at prostaglandins. When we talk about we talk about capsaicin, we'll be talking about substance P, and you'll see with serotonin, we'll be talking about some of the agents we have that interfere with its reuptake. But essentially, here's the soup. Like it or not, you're going to get that soup stirred up. And when we talked about this surgical situation, you can see that soup is really whipping up through the surgery, okay? This happens all the time. So now we have the soup, the neurochemical soup, and we have to convert it to an electrical charge, okay? Then the impulses travel to the spinal cord, to those special cells in the dorsal horn. Then it goes to the brain, and the brain sensory cortex responds that it's painful. Now, there are some neurons from the brainstem that can release endorphins. So you've heard of situations where people didn't know they were injured during the process because so much endorphin and also catecholamines were stirred up. But essentially, you can go to the next slide. That's okay. Essentially, go one more.
Oh, one more.
Because I'm
Okay. There.
okay.
That's where we need to be.
Go back. All right. Okay. Oh, you're not supposed to. The handouts are what? Okay. So if we could take a minute. You can.
Slide you on.
Yeah, that's it. No. Yeah, that's it. Okay. I want you to read what this says. It says the harmful effects of unrelieved pain. It doesn't say injury, disease, tumors, or whatever. Just pain alone. And take a minute and look at what unrelieved pain can do. And this is taken right out of McCaffrey, her book, and you can take anything out of her book. It's not copyright protected. Okay, are there any surprises on there? You all knew just unrelieved pain would do all this? I don't think so. Just think of a diabetic coming out of the recovery room. Look what metabolic. His glucose is off. Look at the cortisol. Look at the antidiuretic hormone. Look at the cardiovascular. All of these things. There's nothing. Is there anything there that any of you want to ask a little bit more about?
Increase the growth hormone.
Well, it's affecting the pituitary.
If that was that, I should have slammed my finger in the door when I was little all the time.
It's just part of the endocrine system's response, okay? And that would be pituitary. You can see also the antidiuretic hormone also comes from posterior pituitary, and you see the epinephrine that comes from the adrenal glands. You see how it's all off.
The immune system, depression of the immune system.
That's an important one, yeah. Developmentally, too. Does anybody have any question about future pain? Do you know what that means? Okay, well, really future pain, phantom pain we're treating a little differently, but future pain really has to do with, if I give you an example, let's say you go to the dentist and you have a 3-part procedure, and that's going to be uncomfortable, but he says, this isn't going to hurt too much. The first one, and it really hurt, okay? Yeah, but the neurochemical soup got whipped up pretty good, right? Now you're in the waiting room waiting for the second procedure. You can stir up the neurochemical soup. Right, so you have the chemistry in place, so when he hurts you again, it's going to be even worse. And then the third time, you see what happens. The reason this is important to know is that many patients with many diseases have procedures serially, and if you don't manage the first one well, it's going to be hell for the rest of the time. So it's critically important to do that, because all future pain then is perceived through the neurochemical soup, and everything's going to be worse. Quality of life. What do you think about that? Yeah?
If anybody seen anybody in severe pain, they're like, just kill me now.
Yes.
Don't
Yes.
take it anymore.
Chronic pain patients commit suicide. I was doing the lecture last year down on South Lake, and somebody came to me afterwards and said her son committed suicide because he was getting blown off by an indifferent person who just said, I can't be giving you these narcotics all the time. Again, not understanding. So he killed himself. So that is an issue with people in chronic severe pain. So remember this. So when you when you go to clinicals, tuck it away. So when you see some chemistry off or some different things, maybe it's just the patient's under-medicated. Okay? Phantom pain is treated differently. If we can do something before surgery, it's neuropathic pain. It is. There's no organ there or no limb, but they're still feeling it. So we have to address it right away in the beginning and get on it with one of our areas that we use to treat it is anticonvulsants and that sort. We'll get into that in a minute, okay? Because chronic pain really is treated less commonly with narcotics because we have other things that are more specific to the kind of pain. Okay, assessment. How do we assess it? What do you think? Okay, somebody said a scale. We have tons of scales. We have for old people, young people, neonates, demented people, all kinds of scales, okay? What does the scale do?
A range.
A range. It's a screening device. So if anybody says, I did a pain assessment, it's 10 or whatever, that is a screening device. You have a number. The person says, I have pain, this is the number. That gives you some idea of how severe it is, but you've got to investigate and see what's going on and what's causing that pain. So, that was used kind of glibly. Oh, yeah. And you see in the chart, patient reports pain, 8 on a scale of 10. Then, an hour later, good result from pain medication. Absolutely useless documentation, and we'll get into that as we move. Okay, threshold. The point at which you feel pain, and that's different for everybody, depending on their genetics, depending on their experience, depending on their culture. So it doesn't mean you're a strong person if you can take a lot of pain or a weak person if you can't. The threshold is that moment that you feel the pain. Now, assessment by response, we mentioned before that physiologically, vital sign changes, pallor, desatting, GI upset, that's really with acute pain. Communication, you know when somebody talks to you about their pain. You can hear it in their voice. You can really tell. Behaviorally, are they posturing? Are they agitated? Are they splinting? Are they restless? These are things that are part of your assessment. And remember, it may be different for some patients, but essentially these are the behavioral responses we expect. We can have denial. A lot of elderly patients who've had malignancy deny their pain because they're afraid that if they say they're in more pain, their cancer is worse, and they don't want to tell the family. So those are the people. Concealment, sleep. A lot of the patients just sleep. Now, they're not sleeping comfortably, but they're exhausted, so they fall asleep. Now, I don't think this is in your textbook, but this is really important to look at the lab values, okay? So when you're assessing a patient, you want to know what the lab, particularly liver function, because all narcotics are metabolized in the liver. So if you have a patient who has a really bad drinking problem, we got to think about that. We better think about how we're going to manage this, or what mode we're going to deliver it in. Okay, then we have the kidney. I'm sorry, I thought it looked like a liver. Okay, this is critically important with nonsteroidals. And when we spend the time looking at how nonsteroidals work, let me tell you, they're dangerous when you have impaired kidney disease. Okay, red blood cells, hemoglobin, hematocrit. We need to address this when planning care. If their hemoglobin is low, they're not getting enough oxygen. There are all kinds of things that can be affected by that. White blood cells, infection. Now, these things will become important when we're using interventional techniques, okay? And, of course, coagulation. You're not going to do a nerve block if somebody's platelets are very low. Now, as I said before, there are lots of assessment tools. There are nonverbal tools, there are adult, geriatric, pediatric, neonate. These are great screening devices. But the most common one we use is the scale of 10. And if you speak English and you can understand, and you can respond to if 10 is the worst pain you can possibly experience and 0 is no pain, what is your number? That's the patient's reading, if they can do that. If they can't, we'll find other ways to measure it. But we should have the same measurement be used consistently from shift to shift. So if somebody else says happy faces, say he's in pain, and 10 on, that's confusing, because you want, when you're giving medication or you're trying to do different interventions, you want reliable data on what you did and how it worked. Cultural differences between the nurse and the patient can impair communication and compliance. There can be language barriers, and we all know now you just don't get the porter because he speaks Vietnamese to ask him to interpret for a patient. We don't do that. We have to be part. I mean, even family members. Supposing the patient wants to say something but wouldn't say it in front of a family member. So we know that the hospitals have to have these very expensive translation hookups so that they get the question in their language appropriately. Attitudes, of course. Beliefs influence the meaning of pain and affects compliance. And there's lots of evidence-based research on cultural differences. Now, there's another part of culture that you're going to be seeing more and more. We're learning that there are some changes, genetic changes. For example, Asians are not able to metabolize codeine. Can't do it. Codeine degrades, we'll talk about that in a minute, to morphine. So they're not going to metabolize morphine. Knowing that, when you say, look, I gave her the medication, she's still complaining. So much of what we're learning now, for example, there are certain hypertensive medications that Afro-Americans cannot metabolize, and then when somebody says they're non-compliant because their blood pressure isn't being affected, they're not up with the research on that. Okay, aging alone affects pain. And this is hard for you to see in detail, but the University of Florida's researcher, Dr. Yuzorski, worked with mice. Now, these are very special mice, I want you to know. You just don't go to a ghetto and get mice. These are very expensive mice. They have to be genetically perfect. They're expensive. They're like $1,500 a mouse. So anyway, so that your results are appropriate, not, some ghetto mouse. So anyway, he found out that just age changed the way the mouse perceived pain, which brings us to a whole area that we have to research. So many elderly people have back pain and all kinds of pain, and our models that we have now are not affecting them. We got to do more research on that. What is changing so that we can address it? So that's what a lot of research is being done on now. Okay. All right, the patient's description, the intensity, the location. You want to do vital signs, it's okay. Quality, what makes it better? What makes it worse? What's their financial or their support system? I presented at ASPN a paper on psychosocial factors affecting pain. And we discovered, because we did with acute pain in an acute care facility, that people who had the most environmental, marital, financial problems were very much likely to have greater amounts of pain. Not because they're flaky, it's because it just added that. And so really the direction of pain management today anyway is multimodal. You've got to deal with everything, not just giving them medication. Okay. That's it? Oh, the documentation standards? Okay. All right. Now, actually, each facility will have their policy on documentation. But what you need to know, and what's great to see in a chart, the patient's pain, what the intensity, all of the things we just talked about, and the patient was giving oxycodone 325, and when you gave it, the patient's pain was 7, and it's now 4. Okay, that's great. That says we're in the ballpark. You know it's going to take 3 shifts to get it under control, right? So we're in the right ballpark. But sometimes when we have range orders, the danger in that if people are picking out different ones, they were made, you know what I mean by range orders, right? You can use morphine, you can use this, you can use that. So Nurse Ratched gives them the codeine, somebody else gives them Vicodin, somebody else. There's no way of seeing whether the agent is really effective in changing pain. So it should be communicated from shift to shift that we use this and we got this result. That will help us know whether we have to increase the dose or whatever, or decrease it maybe, depending on the results. So documentation, at least, you know that most of the oral agents last you should get a response within 30 to 40 minutes, and that's when you go back and you say, what's your pain now? Okay, and document that. Okay, non-pharmacological interventions. Now, you know that I said we have to be multimodal, especially with chronic pain patients. They need to have all kinds of other things in addition to medication. You all know what TENS is, right? Have you seen TENS? Okay, what is it doing? It's breaking electrical signals. Now, people get it, put it on, they put the belt on, they crank it up to the largest amount, and keep it going, and then they come back, this isn't working, this is no good at all, because they didn't get instructed to do it 12 hours on, 12 hours off, and don't crank it all the way up unless you need it. So they need a lot of education on how to handle TENS. Heat, cold, pressure, these are good things. Massage, vibration, sometimes just even vibration works. Now, the complementary interventions would be acupuncture. That's the only intervention that the National Institutes of Medicine Alternative Medicine Division approved of for pain control, okay? Because it's very hard to use a Western scientific method to investigate things that don't fall easily into that. But acupuncture has been successful. Glucosamine sometimes for bone pain. But then there are also things like that you can add cognitively and behaviorally. Music, guided imagery, relaxation, hypnosis, distraction, therapeutic touch. But let me tell you something. If someone comes into your ED in a lot of pain, don't say, I'll put this music on for you. All right? That's not a good use. You're going to deal with it, but these are things later to make it easier for them, okay? Also, I don't know, I do therapeutic touch, and I did my undergraduate work at New York University, where Dee Krieger, who's the leader in this, was there when I was an undergraduate, and when I came back for my doctorate, she was on my committee. So I do that, and you'll see people coming to my office, and I'm doing funny things. It's people come from all over, and if you want, I'll do a demo sometime for you. Sometimes the students like to see that. Okay, so it's an Eastern technique. It involves the same things that acupuncture does, the meridian system, and the Eastern system of chakras. It involves it all in one nice package, and it clears the tension out of your field, and you get relief. Okay, so I know how to do that, and I'll be happy to teach you. Yeah. Well, acupressure is going to the point, but I'm not touching you. And I liked doing this because a lot of people do not like to be touched. You know, so using therapeutic touch on the field, it would be like around you, and I'll pick it up and clean it up for you. Yeah. Are we getting close to break time, or?
Yeah, we can take it.
What do you want to do? Want to go on for a minute more, or keep going? Is that the consensus? You're not in enough pain yet, right? Okay. Okay. Our pharmacological management really involves three separate categories. The opioids, and most of them turn on mu receptors, so they're agonists, mu agonists. And then we have some opioids that are agonist-antagonist, and they're not used very often. They're used under very special circumstances, so I wouldn't spend a lot of time except to know that they exist, and if you're taking care of a patient who has it, it would be like Stadol and Nubing. And they found them to be highly addictive, more so than the other mu agonists. Okay, then the non-opioids, which are our non-steroidals and our acetaminophen. And then we have adjuvants, and those are things that are used to treat other things, but we found them very, very helpful in pain management. Anticonvulsants and tricyclic antidepressants, they are really the gold standard for neuropathic pain. And then we have some other things that you may or may not want to get into in any detail today, but alpha-2 adrenergics, then there are local anesthetics, there's NMDA antagonists, sometimes steroids are used, especially for tumors. So some of these are very effective just by themselves without anything else. So if you, first of all, have properly assessed the patient, you know what the pain is, and the physician is also in that category, and then they'll know the appropriate intervention to start with. This is not an exact science, so we play. That's why our assessment is important. How are you doing? Well, we got it down to 7, but that's not enough. I found in my experience that over 5 for most people, you really can't function. You really can't. It's just distracting. Okay. All right, now we can get it into the patient, believe me, orally, rectally, IV infusion, we can do IV boluses, we can do nasal, we can do PCA, we can do epidural, and we can do topical. So there is no one that can't get some of the effects, okay? And you'll see, for example, if in hospice patients that when we don't have a line in, sometimes just under the tongue, because your mouth is so vascular, it sucks up that liquid morphine very quickly. So don't ever feel that you will not be able to get the patient's pain under control because you don't have an IV line in or whatever, okay? All right. Oral, of course, is the most inexpensive, non-invasive, simple. It's slow in onset, but it's just as effective as other routes if it's done round the clock, okay? There's no reason why, if you're doing well every 4 hours, it's just as good as an IV, slowly putting something else in there. And it's preferred in cancer and chronic non-malignant pain management. Now, intramuscular, God, we used to use it all the time. Thank God we're not. It is the most unreliable, and it's the most painful. Unreliable because the amount that's being absorbed from the muscle is not something we can actually say with any degree of accuracy. Plus, people get sterile abscesses and fibrosis of the muscle. That's not something, I mean, one shot in the emergency department, that's okay. But to continue, no way. It's a very poor choice for elderly because they have decreased muscle mass. Even though they may be thin, there is a shift to more fat. It's just the shift, and they have less muscle mass. So then if you're sticking a needle in that muscle, it's going to be infinitely more painful, and it's not going to absorb too well. It's a very poor choice for children. They hate it. Intravenous is most effective when because if you need to get somebody's pain under control immediately, and you can rapidly titrate it. You can maintain a nice steady state, and of course it depends on venous availability and continued patency. It's also expensive and requires expertise, and you have to keep changing the IV lines and that sort of thing. Subcutaneous is coming back. It's something we used to see used a lot, and it really is just the subcutaneous tissue, usually in the abdomen or the thighs, and it's coming back more. And you may see it in hospice when people are unable to take oral medication and they don't have any venous access. Very bad stick. So absorption and distribution depends on where you put the needle, and also it's easier. I mean, you can give boluses, but very different concentration. You don't put, like in an IV, you put a medication with 500 cc's. You don't do that in a crisis. Can you imagine how much you'd be filling them up with? So you got to know what you're doing, and you'll see that coming back. Okay. Topical agents. Lidocaine and lidoderm in the patch. This is becoming very, very helpful with post-herpetic neuralgia shingles. This is one of the fewest patch. It's the only patch that you can cut and shape. So if somebody has an event here that goes across their back, you can actually cut the patches to go along that. 12 hours on, 12 hours off. Now, the company, lidocaine, as you know, can cause cardiac dysrhythmias, right? So you don't want to fill anybody up with lidocaine. So the company figures out, how much skin would require to absorb how much. So the patches are safe, and you can cut them. Now, let me tell you this, though. Only apply to intact skin. So if they have blisters, or the blisters are weeping, you don't do it, because they'll suck up more lidocaine. Then you've got a different issue. Now the patches are about this size. It said 3 a day. You'd have to be a big person to need 3 of those patches. Usually in the pack, you just cut one along and go along. 12 hours on, 12 hours off. And it's very effective. Now, capsaicin. Have any of you seen it?
It's in a cream. Right?
Yeah.
Like Bengay, but not Bengay.
Right, because some people think it's like Bengay. So you see them in CVS, they're telling each other, use capsaicin. It helped me with my arthritic knee. You need to know what you're doing when you're applying capsaicin, because go back to the neurochemical soup. It's substance P that we're addressing with capsaicin. So what it does, now you have to have a cooperative patient and one that will understand how to use capsaicin. You just don't rub it on and hope things get better. And God forbid you put it in your eye, you'll need morphine, okay? Because it's made from hot chili peppers. And it was derived when people doing some research noticed that people in different Asian countries that had very hot, spicy food had a very high pain tolerance, and that was the beginning of the research. So it's really hot chili pepper, all right? And now, if you had a sore knee, and I told you it will work, and you put it on and it hurts so much, you say, are you crazy? It hurts more. We've got to train the patient to know we have to deplete the supply of substance P. So you're not going to get relief. It takes time for you to, what you're doing is you're forcing the release of substance P, and then eventually they can't do it anymore, and they get relief. If they're not well informed, they stop doing it, and I got to go through the whole thing again. So you really need to know how to use capsaicin.
How long does it take? I mean, does it vary? Is it
Yeah, it does.
months?
Not weeks or months. You couldn't tolerate that for weeks or months. Usually in a week, they'll see it's changing because they're exhausting the production of substance P. Okay? Yes?
This might sound like a stupid question, but can you explain to me, like, is substance P, is it a hormone? Is it a...
It's a chemical produced when there's injury or pain.
Okay.
And that's part of the neurochemical soup. So every time you have an injury, you're going to have the whole soup, and this is just one ingredient. Okay? Does that answer it for you?
Kind of.
Okay.
Like, is it released, like, what is it released, like, what part of your body would it be released
The
from?
neurons.
It's a, okay.
Okay.
That makes sense.
Okay?
Increased pain.
Initially, your goal is to stop the production of substance P. So what you do is you apply it and put rubber gloves on or disposable gloves when you apply it, and then by the time you do it a few times, you start to get relief, and about a week later, if you do it like 3 times a day, you can't produce substance P anymore because you've exhausted the mechanism to release it. Okay? Yeah?
So you can't produce substance P anywhere in your body or to the site?
To that site, as
To
far
that site.
yeah.
And can you, once you hit that relief state, the days or the week, can you use it forever?
You can. But if you stop using it,
If you stop, then you got to start all over.
yeah. Okay. So it's not as safe, and I really feel badly for people who are feeling kind of blown off by their healthcare providers, so they go into the drugstore and they're looking at different things. And if you see them with capsaicin, you wonder, my God, about a lot of the stuff.
Okay, so that's over the counter?
Yeah. Mm-hmm. Yeah.
Like going to the store and buying Band-Aid.
It's, yeah. Okay, where are we? All right. So I told you about the lidocaine patch, the application, okay? We can move on from there. Okay, these are the problems if you use it inappropriately. I said you can have some dysrhythmias, cardiovascular, but if you stick with the amount and you stick the 12 hours on, 12 hours off, this is the lidocaine, and you only go along the nerve root that's in question, you shouldn't have any problems. Okay. All right, there's some controversy over this. There are groups that say all these medications and narcotics that are getting thrown out and flushed down the toilet are affecting our water supplies, and maybe we'll have weird-looking fish or whatever they're worried about. And it is a concern, the stuff that goes in there. But as of now, we are to flush the patch down the toilet, okay? That's the latest, okay? Now, in any of these things, and especially when we get to Duragesic, a lot of elderly people would be using this stuff. Okay? They usually have grandchildren and pets. You don't want that stuff in the garbage because an infant or young child's body surface is different, and a pet, if they start licking the patch, they could die or be seriously impaired. So that's what, so whenever we have somebody on one of these patches, we very carefully assess who's at home, okay? And be careful, because even a spent patch has enough in it to hurt a young child or a pet. Okay, all right. Now this is kind of heavy, but it'll lighten up like the soup. Do you want to take a break now? Okay, how long did they get a break?
About 10 minutes.
Okay, all right, we'll do that.
Okay.
Next.
We're ready.
Okay.
Next one.
All right. Like the gate theory that looks so complicated, I'm going to make this really easy for you, okay? When there's cell injury, we break down arachidonic acid, and we have all of these wonderful prostaglandins, okay? Next. I'm going to talk about each one of them in a minute. Okay. Prostaglandins are very good things. You don't even know you have them, and they're working right now to make you healthy. Okay, what did they do in your GI tract? They increase blood flow in your gastric mucus production, gastric bicarbonate secretion, and they decrease gastric acid. So that particular one is really very protective of your gut, okay? Then we have some others, and I'm never going to hold you, or no one will, to whether it's PGE or whatever. But the other good thing it does is renal vasodilatation, okay? Also, it inhibits sodium and chloride reabsorption beyond a certain point. They produce fever, and that's important when you're sick. That's a normal mechanism to burn out the disease. They cause uterine contractions, so oftentimes prostaglandins are given during labor. And they, look at the bottom one, increase sensitivity to pain. All right, these are normal things that are in our body, and they're good things. And we would want to have an increased sensitivity to pain, because you wouldn't do anything about something if it was not causing you pain and it was injurious, okay? Now, when you inhibit prostaglandins, you get a package deal. You decrease pain sensitivity, and all of those other good things gets decreased too. So if you have renal disease, there's not going to be any dilatation of the vessels in your kidney. Whether you do or not, it's going to irritate your stomach, and it's going to cause a GI bleed. So you have all of these things that are happening because all we want to do is decrease pain sensitivity. But once you're aware of what these things do, you'll realize how risky they are in some circumstances. Okay. Now, aspirin is the mother of all. It's called a COX-1, but we'll go right to the next one, which is ibuprofen. Okay, that's also, okay.
Want to go back? Where do you go? You okay?
I'll work around it, okay? So if we inhibit these COX-1 agents, what are we doing? We cause GI irritation, renal ischemia, increased bleeding time, and rarely anaphylactic reactions, okay, because of the leukotriene production. Now, do you think you could go back to the chemical thing?
The chemical one?
Yeah, back to that one. And one more. Okay. That's it. So this looks very complicated on this chart. But over here on the thromboxanes, what do? They interfere with platelet production. All the ones down there, a variety of uterine contraction and that sort of thing. The leukotrienes over there, they have to do with bronchial dilatation. So all these good things that are supposed to be happening, and when we take a COX-1 agent, whether it's aspirin or it's ibuprofen or any of the other ones on the market, there are tons of these things. They come under different names. Okay. These are good things. We're going to inhibit them in the service of relieving pain. So when you're doing your assessment of patients, you've got to realize what this stuff does. Okay, we can go 3 or 4 now. Yeah, one more. Go ahead. Okay, another now. Okay. Now, this is the range that we think about for analgesic amounts. For ibuprofen would be 12 to 1,600 milligrams a day, not more, even though some people take it. Then there are anti-inflammatory doses that are higher. You can take ibuprofen for fevers. But remember, it inhibits platelet production, okay? The difference between inhibiting and destroying is the difference between aspirin and ibuprofen. Aspirin destroys the enzyme for platelet production, and it doesn't return to healthy development of more platelets for 7 to 10 days. Hence, why do they say before surgery, no aspirin? Okay? Or ibuprofen. Now, ibuprofen isn't as bad. In about 5 half-lives, it had inhibited platelets. It didn't destroy them, but you get back to full tilt in about 5 half-lives. Okay. So that's very important to recognize. So when you totally inhibit platelets, that's not the time to be doing surgery on somebody. So it's important to know that. Okay? Next. All right, now the next chart, we'll give you the story of COX-2. COX-1 are the aspirin ibuprofen groups. And you just heard they're good things, but when we inhibit them, we inhibit good things. So all of a sudden, when the COX-2 groups came, the Celebrex and the Vioxx, we thought, thank God, because it's a selective inhibitor. It'll go to inflamed tissue, and it will not affect all of the things that the COX-1 group does. Now, they were doing really well until they had people in nursing homes that hadn't been getting up with some Celebrex or Vioxx, and Vioxx was the one they used more frequently, hence all the legal things. They didn't watch the patients who then developed congestive heart failure and some arrhythmias. They were just so glad they were up and walking around, nobody was checking it out. That's what really happened. These were good drugs. If you had to take something for inflammation, an anti-inflammatory, it would be safer to take one of those rather than doing what we do to our kidneys and our lungs and our platelets with the other. So it was promoted and seen as the answer to all of the problems we have on this side. But because of other things that were not being watched, they were taken off the market. Now, Celebrex has stayed on and is used in certain circumstances. But it was the overuse of them and the little carelessness because they were not doing that, they weren't watching other things. But you may still see some Celebrex being prescribed. Okay, so does everybody understand the difference between COX-1 and COX-2? COX-2 was our answer to all of the horrendous things that happened with COX-1. But it didn't work out that way. Yep?
Meloxicam. I'm seeing a lot more of that. Does that fall under?
Is that Mobic?
Yes.
Okay, that's
And
COX-1.
that's
It's old, but it's a combination of COX-1 and COX-2. So it's a little COX-2 and a little COX-1. They're not as frightened anymore. And, of course, there are legal firms that really are making a fortune on Vioxx. And I will tell you, that it was over-promoted, and everybody got on the bandwagon and forgot the safety. Didn't look for other things.
So with the meloxicam, then if you have a patient that's using it routinely, you would be watching.
What would you want? Right.
Stomach upset.
Right.
Counts,
All right. Now, there is something you can do. If somebody really needs to have a prostaglandin inhibitor, like a nonsteroidal, there is an artificial prostaglandin, misoprostol, that gives you the protection for your gut, because there's something like 75 million GI bleeds a year because of the use of nonsteroidals. People get fed up with not getting relief, so they just take as much as they want, and there've been deaths. Well, anyway, if a person legitimately needs a higher dose of this and you want to protect their gut, there is an artificial prostaglandin. Now, if someone says, well, just take it with meals or take an antacid, it's not going to work. Because remember what we said it does. It increases mucus production, much more than just reducing the acid. So there is something if somebody needs that.
And how do you say that again, Vista?
Propel. I'll figure out the spelling in a second. I'm trying to think of the brand name. What is the brand name? Okay, we'll find out. But it is an artificial prostaglandin. Okay. Now we can go, because I just told them the whole booty. Okay, so it's Celebrex and Vioxx. Those were the names, and you know the story. Now, when would you not recommend a nonsteroidal? Of course, persons with kidney problems, a history of peptic ulcer disease, and people who are actively bleeding. That's okay. Okay. Yep, that's okay. Now, don't use multiple nonsteroidals at the same time, with one exception, the 325 baby aspirin for cardioprotection. That can be used. Expect ceiling limitations, and there is a difference between analgesic and inflammatory dose ranges. Okay. All right, now we do, Toradol is the one, you all know that one, right? As of last year, was our only parenteral nonsteroidal. But in Europe, for years, they had parenteral ibuprofen and parenteral acetaminophen. We have that now. Okay, they tested it for many years, and we have that now. So you can go. Okay, here's the Toradol. You give it IM, IV, NPO, but there's a limit on how often and how many days you can give it. And it appears on the Beers list. Do you all know what the Beers list is? It's not a nightclub list. It's a list of all of the medications dangerous to or should be used with caution for geriatric patients. So when you see that BEERS, you'll know that that's a red flag for it not to be used with geriatrics. Or if you use it, be careful. Next one. Okay, here's the ibuprofen IV. So it is now. We have it. You'll see it used. I've been concerned about whether that's gotten to the state boards yet. I don't know. I wish I knew, because usually one of the wrong answers was, no, you can't give ibuprofen parenterally. Well, you can now. So I know that next year they're changing the exam, so I don't know. But be aware that you can do that, and these are the specifics. Sometimes they give it before a procedure to reduce inflammation. Go ahead. Next. It's called caldalog, and here it'll tell you how to use it, okay, for fever or for pain. Now we're going to talk about acetaminophen or Tylenol. It is not a nonsteroidal, okay? Acetaminophen is not nonsteroidal. It inhibits prostaglandins somewhat, not in a major way, because it's primarily it acts centrally. It has minimal anti-inflammatory qualities. So if you sprained your ankle and you needed a nonsteroidal, you needed something, you would be better off with ibuprofen because you have inflammation. You want to decrease the inflammation and the pain. But if you didn't have inflammation, you wanted Tylenol, okay? It has direct hypothalamic activity, so use it for fever as well. And it, too, is now available parenterally, first time. So, again, the same thing that you'd use it for if you were giving it orally, but this is IV now. And there are some specs on it now it's only approved with patients over 2 years of age. And you'll see what the provision here is to do not exceed the maximum daily dose. Now, there are 75 people always on the liver transplant list because of an overdose of acetaminophen. It's very, very destructive to the liver. So it's really bad. So if you see people taking a lot of it because they want to they'd be safer with a low-dose narcotic than taking the acetaminophen. So it is a dangerous drug to overdose on. Okay. So this is just some information on how that drug comes. Okay. Now we're going to tell you a little bit about scheduling narcotics. Do you know how they got scheduled?
People were using them out of control.
Excuse me?
They were using them.
Well, how do they come up with Schedule 1, Schedule 2, Schedule 3? How do you think that happened? Anybody have any idea?
Oh, is it a HOA thing too?
It what? Oh, yeah, that's what it means. But how do you think they figured that out?
They were giving medication that
To incarcerated volunteers. Are you going to trust that schedule? You know, this is what they did. They gave them... Now, Schedule 1 we don't use in the United States. We do not use heroin, LSD, cannabis, peyote, or ecstasy in the United States, legally. Okay? All right, so they didn't give them that. Yeah? Oh, right, Marinol. I'm sorry. Under controlled conditions, yes, and they're trying to... Yeah. I'm sorry, yes.
Getting away from using that so much. At least our hospice doctors are told not to use that unless it's the absolute last resort.
Yeah. Well, if somebody's smoking marijuana, it's a lot different than Marinol, okay? And so I got sidetracked there. I'm sorry. Go ahead. Yeah?
Question is ecstasy. I know that when I was in the Army, they were using MDMA as an adjunct for
Okay. All right. No, there's... Are you sure? NMDA. Is that what you're saying? Or you're talking ecstasy? Because are you sure that it wasn't NMDA? Because in very unusual neuropathic pain syndromes, we do use those. And it's in, ketamine, and it's in dextromethorphan. That's why you can't buy a lot of cough syrup, because it has it in there. So in very unusual neuropathic pain syndromes, yes, but it's not ecstasy. If they were using it, I don't know why. So, okay. Research, sure. Okay, so just imagine if you were incarcerated. Like, it's boring, right? And here you are. So you're part of a research group. So they don't give them one, Schedule 1. They gave them Schedule 2, and they go, whoa, that was good, Schedule 2. So then it became morphine, opium, dilaudid, methadone. Those were Schedule 2. Okay, so that was a real high. Next one. Then 3, they have some potential for abuse, but less than 1 and 2, and there may be moderate dependence. So what's Schedule 3 usually? It's ketamine, anabolic steroids, Tylenol with codeine, Vicodin. Now, the reason Vicodin was the most commonly prescribed oral preparation in the United States is because it was a Schedule 3. And the difference was because when you had to write Schedule 2, there was a special prescription pad, and there were 3 copies. One went to the feds all over the place, and it was hard, and every once in a while they changed the numbers, so you had to buy a new one. It was a nuisance. So when Vicodin didn't need to be Schedule 2, that's why Vicodin was used more. Okay. Schedule 4, they have a low potential for abuse, and of course, they didn't get that high on it. So these are the things that are in Schedule 4. All right. So I just thought you might like to know how this scientific study was done. Okay, Schedule 5 would be like low modal, cough preparations, stuff like that. There is some narcotic in it, a very low potential for abuse. But if you have people taking a lot of, you can't buy a lot of particular cough syrups because you could be abusing it. So they're trying to watch all of that. But anyway, I thought you might like to know how these schedules were derived. But they exist, and we have to adhere to them. Okay, most of the narcotics you'll be giving target the mu receptors. And when you target the mu receptors, you get a lot. You get a package deal. You get pain relief, but there's a price with it. Nausea and vomiting, constipation, sedation, respiratory depression, pruritus, and urinary retention. Okay, that happens with every dose. Now, the most serious is the constipation, because that never goes away when you give a narcotic. So the moment you put somebody on a narcotic, they should have a bowel regime prescribed as well. And usually there are standing orders. I was involved as an expert witness on a case where they kept giving this woman more and more narcotics. The end of the story is nobody ever gave her any bowel preparation, and she ruptured her bowel and she died. So, and it was so clear in the record, wait a minute, you've been doing this for how, and you never thought about this, and they keep giving her more and more. So, even though actually nausea and vomiting is terrible, but it would go away if you didn't medicate for it. And usually people will stop taking the medication, but it's so much better to pre-medicate, to give them some anti-nauseant when you prescribe, and tell them it'll go away in 2 days, but let's take this beforehand, okay? As far as respiratory depression, that's a concern when it's the biggest concern to everybody, that they're going to stop breathing. Of course, that would be a concern. But the thing is that it's not going to happen all of the time. And if you're careful in your assessment and you're monitoring the patients, you can deal with it. Okay. Now, morphine is the gold standard. It's been around forever. In the Iliad and the Odyssey, it's discussed. It's there. Okay. So, okay. Go back one. Okay, now, it is slow, IV. It's slower than others. So when people say, and you see it in your book, that it's real fast, no, it's 30 minutes. And that's very important when you're pre-medicating for a procedure, because sometimes during the procedure, a doctor may say, give them morphine. That's not going to help now. So we have to know the duration, okay? It peaks in 2 hours, and it has a 4 to 5 hour duration. Now, it has 2 major metabolites that can be troublesome, okay? Glucuronide 3 is about 10 times as sedating as the dose of morphine. And the other one, 6, acts like Narcan at the mu receptor. Now, when are you going to see this? It's so rare. It's so rare. But if you have a patient who's not metabolizing it, or what they're filling up with is the metabolite, you're going to get excessive sedation, or you're going to get something like no medication at all. And that was one of the consults that we did on a team. This woman was 4 days post-op laminectomy, and she's in a chair like this. And they're saying we're giving her morphine constantly. We went and looked at her labs, and we gave her a 0.5 milligram of IV dilaudid. She was relieved of pain right away, and she wasn't overly sedated. So, and then we got her back on the routine. So that was a rare one. Where are you going to see some of these rarities? In elderly patients. If you can't metabolize and you hold on to the metabolites, it's going to produce some very serious problems for you. So morphine is very commonly used, and it's usually okay. And just be aware, though, if you run into trouble, you got to ask some questions. Okay. Now it comes in oral solutions, tablets. It comes in long-acting preparations. It comes in suppositories. It comes in many, many different forms. Now, there's a new one on the market called Nucenta, and it also goes to the mu receptor, but it blocks the reuptake of norepinephrine. Now, you know what do the tricyclic antidepressants do? It prevents the reuptake of norepinephrine or serotonin. Any of the, well, tricyclic would be norepinephrine and serotonin would be the SSRIs. But that's an aside. The point is they're thinking this is better because it prevents reuptake of norepinephrine, so they should have more norepinephrine pooling at the site, so their mood will be better, and there'll be some mild agonist activity at the mu receptor. So this is what they're pushing for now, and they're hoping it's more effective than something without it. Now, tramadol was the first generation, and this is second generation. Tramadol had a lot of problems, and you never mix these with others, okay? Well, you shouldn't do it with most of them, but this can be dangerous because as we can see that if you give another narcotic with one of these, you can really strip the mu receptor of what's in there and make their pain worse. It's just an odd combination. So this is what you might see. And again, you're not going to memorize all of these. Just learn them in classes, and then as you're giving them to your patients, you'll know. You'll know that this is 4 hours, this is whatever. You never mix these two. You always look it up. You always check that, always. And actually, I do too, because you never know if something new. I'm always looking for new stuff. And for example, I'm constantly getting updates on a variety of things. And this was the ibuprofen when nobody knew about it and it was first coming out, IV. So you've got to be looking all the time and knowing what you're giving and what you expect. And I believe that checking the labs on the patient is really, really important. Okay. Yeah?
If you're giving some of the patient that medication, then any antidepressants that might be on would be a consideration as well.
Well, yeah, you've got to look at that. Now, you've learned something about Nucenter that people may not know. So if they're on an antidepressant that's preventing, let's say serotonin, preventing the reuptake, and this is also adding, you could put them into a serotonin crisis. So that's why you have to know your medications. All right? I like the pure opioids without the mixes, because, but if you check the patient's medication, you'll know it. But you're right. So you could get into a lot of trouble if you didn't know what it was also doing, and the patient was on an antidepressant. Okay? All right, this tells you, yes?
I was wondering if you shouldn't give like tramadol for breakthrough if somebody's like on morphine.
No, never. Are you seeing that?
Yes.
What?
That's my job. Just saying.
Now, either you have a brilliant pain manager there, and they have something to teach us, or you don't. Tell me what they're prescribing.
I was just thinking that I had morphine and it had some tramadol as a breakthrough.
What were you seeing in the patient? Any results? I would love to know the rationale for that. And why would you use another agent to break through? Makes no sense. Why don't you stick with the same agent?
So the same.
Yeah, the person was on morphine, and let's say they were on a long-acting agent, and they had breakthrough pains. They needed more. Why don't you give morphine? And then what you do is you add up how many times they need breakthrough pains, and then you add it to the long-acting ones so that they get even coverage. And this is with a chronic situation, but that's bizarre to me.
I had a patient who, she came in and the doctor, she was on the Percocet, but then she kept complaining of pain, like within 4 hours, 2 hours of getting the Percocet, she would complain of the pain. So the doctor put her on Lidoderm with Lidoderm patch as well. Then she said she didn't want the Lidoderm patch, she wanted the Duragesic. So he changed it, gave her Duragesic. But then in between that, she was saying she still had pain. He put her on the tramadol. So
That's such a mess. How can you evaluate a patient who's just had lidocaine, tramadol, and
she was on Percocet, basically getting Percocet every morning and every evening. Then she has the fentanyl patch on, and then in between she complained of pain. She gave her tramadol, and she said she's good, and she was happy with it.
we'll talk about that patch. Yeah.
I just got an email from my nurse manager. I work in med-surg floor, and there's a specific orthopedic surgeon that at this point, in addition to his morphine PCA, he wants whatever he's ordered PO given as a scheduled med, even though the order is written PRN, to give as a scheduled med for the first 24 hours post-op.
That might work. That might work. These other things sound a little hinky to me.
Well, I think it is because you have these patients in the rehab unit and you're like, okay, they're having all this breakthrough pain, so you call, you're not allowed to call the doctor, you have to call the ARMP, and the ARMP's like, I can't do anything about that.
Wow.
That's their favorite thing to give is tramadol. You know why? Because in Florida you can't give any scheduled drugs. The tramadol is the highest amount of pain medicine an NP can give.
Did you hear that answer?
Y'all know why. Correct. You have an understanding of, as an NP, for pain, the highest I can give is right for is tramadol.
Right. That's what she would say on the phone. But
Right.
then she would never relay it to the doctor. He'd only come to the facility
Right.
maybe.
Right. And in Florida, I think all the docs are in trouble in Florida, as we know.
That's the thing, everybody's scared.
They're
everybody's
overly-
very scared.
They're
scared.
Getting a narcotic for your
Very
patient
scared.
is like,
It's terrible because it's almost undoing 25 years of getting people educated because and if you ever had the DA show up, they come in like cowboys, they're horrible, and they have guns, and they do it in the waiting room. I mean, I've seen it happen once, and then everybody hears that and freaks out. And actually, in Rhode Island, I was giving a conference on pain medication, and there were a couple of DA cowboys in the room, and they're just ready to. Well, anyway,
let's hope they never have pain. Or let's hope they do.
And we can't give them
It's a
anything.
huge problem. It's a very bad problem if you have someone that's in horrible pain.
So
It's
we got
9 o'clock at night.
yeah.
You got an emergency kit sitting 10 feet from you,
And you
and
can't.
you know there's relief in there, and they're saying you can't go pull it till you have a hard prescription, and they're crying, and your license.
Well, I assembled 75 doctors that were in the room as we were teaching them how to give, and these DA guys were in there. So they stood up and said something and really were being destructive. So actually, and I don't know if every state should have every person in the United States prescribing any narcotic is supposed to receive this little booklet from the FDA. So I got copies of them, and I was working with the Attorney General because we were concerned about what we have here, not that there were mills, but that people were so frightened of prescribing. So I bring them in to make them all happy about it, and we have these two cowboys in the room creating a problem. But I had sent for these FDA guidelines. So I'm waiting till they did that. I almost destroyed everything we were doing. So I said, do you have, according to the law, you're supposed to provide one of these for everybody who gets a narcotic prescription. I said, do you do that? So they said, no, we don't. I said, well, then why are you doing what you're doing? If you haven't informed people, you can't charge them with a problem. So you are so far out in left field on that. So we worked through that Attorney General is now Senator Sheldon Whitehouse. He was the Attorney General. I worked with him. So we worked with doctors to prescribe appropriately, and those two guys really couldn't answer the question. And then the Attorney General said, show me that. And he looked at it too, and he said, why don't these people have it? Every doctor in this state should have it. So I kind of thought maybe I should get involved in Florida, but I don't know. I'll see. Okay, let's move on.
You don't want that one.
Nah, that's Nucynta. It's new, and they're always looking for better things. Okay, oxycodone, great drug. does its job. Now, we used to prescribe Percocet, and it was always 5 and 325. Now they've made it in other combinations, so you should always know what are they getting, okay? Because actually, they could get an awful lot of Tylenol, and that would be really bad if you push that, okay? Next. It's an opioid and a non-opioid, and it's good for oral analgesia with young children. Oh, excuse me, Tylenol with codeine. You move fast, okay? The only time I want to see that is with children like post-tonsillectomy. It's wonderful, but it is really useless for adults. If you have to prescribe that, give them Tylenol or ibuprofen. And it degrades to morphine. 10% of the dose degrades to morphine, which is minuscule, okay? Dilaudid. This is a really great drug. The reason it's great is it has no metabolites that are troublesome. It's also faster acting and longer lasting than morphine. So it's a really good drug. You can give it IV, and really in about 5 to 10 minutes, people are getting relief. And it comes, now there is a difference between Dilaudid and morphine and some of the others, and that is, the oral form is so rapidly metabolized that you have to give higher doses. Now, let me back off and tell you this. If you have to switch from IV to oral, patient's going home, they've been on 10 milligrams of morphine, IV, right? And the doctor writes a prescription for 10 milligrams of morphine IV. It's 3 times the IV dose is the oral dose for every one of them except Dilaudid, where it's 5 times, because the oral form is just so rapidly metabolized, more than the others. Okay, so it's a great drug, and it lasts longer, and it comes in oral forms. It is now coming out in a long-acting, like one of the Contins, and that would be good because it's long overdue. Okay. Yes?
I've seen patients who are coming into the hospital stating that they're allergic to every other pain medication except for Dilaudid, so that's the only one that they'll get.
Now, I'd be suspicious of of 2 things. Number one, they know what they're doing. And it's very rare to see an allergy. They tell you it's an allergy because they had nausea and vomiting. So they don't know about all those other things. They think that's allergy. So I ask them, okay, when you're allergic, what is it? But what's the difference? If they want Dilaudid and it's safe and you prescribe it appropriately, fine. But they may know that the other stuff isn't working as well. Yep.
That was actually the drug given to my sister after she came out of surgery. It was almost instant after they've been trying to catch up with it. The doctor finally said, okay, well, we're going to give her some Dilaudid. And she had a little bit of itchiness, but after that, I mean, it was managed.
Yeah. It's a very, very safe narcotic. But the other thing you have to be afraid of, if you have people that are used to prescribing morphine, like 10 milligrams, the equianalgesic dose for Dilaudid is much lower, and we'll see you can't convert it. You can kill a patient giving them 10 milligrams of Dilaudid. So you have to know the difference. And we'll talk about equianalgesic. What that means is what dose of this medication is equal to this dose of this medication. So Dilaudid, although I like it because it lasts long and it's effective and it has no metabolites, you've got to know the dosing on it. And if you don't, you could really get somebody in a lot of trouble. Fentanyl. Aha. Okay, IV, that's the fastest thing we have. There's nothing faster than IV fentanyl. And actually, we changed the procedure in the ED because for closed reduction of fractures, the doctors were closing them and then giving some morphine for the pain. We pre-medicated with fentanyl. The reason they didn't want to give a narcotic because they were in the ED too long. And they knew they couldn't let them go after they gave them morphine for a while. So by seeing that fast on, fast off fentanyl, the patient got tremendous relief right away, and they worked it off really fast, and they were able to leave the ED. It's about 80 times more potent than morphine, so it's a very, very powerful narcotic. Okay, that's it. Okay. It lasts IV only about 30 to 60 minutes. It has an active metabolite. It's not troublesome, though. Okay? You can't take it orally. Okay? But they have fentanyl citrate, which is Actique, and you can do it with a pledget. It's a little pledget, and you pull the cheek aside and you put it up there because it's so vascular in your mouth. That is used for breakthrough pain. The Oralette is the pediatric version of that, and we had to be careful because they were calling them fentanyl lollipops. Whenever you add a word like that to something this dangerous, you have to be careful, so we prefer to use it as an anesthetic induction. Okay? But people who are on fentanyl patches and need breakthrough, the pledget with the Actique is what is used. Okay? This drug I hate more than any drug in the world. Okay? That's pretty strong. And it's what?
Most hospitals aren't even using it anymore. I mean,
They shouldn't. And that was because of our effort to take it. Now, first of all, it has a neurotoxic metabolite. And it makes you confused, and it makes you angry, and you can become a little violent. Plus, you get seizures. Now, the CNS irritability, people just thought, oh, the patient is really, really obnoxious. No, they were getting irritable with that. Now, the mandate is if you have to use it, do not use more than 600 milligrams a day for 48 hours, and then it's to be stopped. It has a fatal interaction with MAO inhibitors, those particular antidepressants, those rare ones. I'm trying to remember, what are their names? Nardil. That's one of them. Yeah. But it's not the problem with this drug, too, is that the oral preparation has, because you have to take so much of it, you're getting the much more neurotoxic metabolites. So actually, there's only one time that it's good. So we've kept it in the formularies in the hospital. Post-operative shivering. If somebody comes out of anesthesia and it's, they're really shivering, it's out of control. That's dangerous. They're really impaired. Their oxygenation is impaired. Just about 5 milligrams IV will stop it on a dime. That's the only time, or the same reaction with amphotericin. The same shivering reaction. But there's no need to use that narcotic. And it was used forever with Visceral IV. And it was just like from the dark ages. Yeah?
doesn't it, when used IV, it does something to the veins? Isn't it like extremely corrosive to the veins because they were using it in conjunction with Phenergan?
The Phenergan is it's terribly toxic to tissue. I mean, people have lost arms because of Phenergan. Yeah, they were mixing it up. But
They would always use, that was always the
it took us so long to get Demerol out of the formulary and changed. And it took this in the state of Rhode Island, where I was part of this pain team. We wrote we first assessed all the doctors as to their knowledge of Demerol, okay? And we had this little thing, and we analyzed the data, and they didn't know anything about it. They didn't know any of the bad stuff. We published it. The next morning, following publication, the medical directors and everybody met, and we got a change in the formulary. So, if you do your work and you do it right, you'll get a change. Now we see this happening all over. Okay. All right, we talked about equal analgesic. Look at the hydromorphone is dilaudid. Look at the difference. Now, if somebody was used to using 10 of morphine, if they gave 10 of hydromorphone, that would be dangerous. You'd kill them, right? So that all that means is this dose is equivalent to this dose is equivalent to this dose. Okay. All right, now, there are no long-acting narcotics. They're all really 4 hours, but there are formulations that will slow release them. And the ones that we hear the most about are the Contents, okay? And they're nice 12-hour dosing. Now, supposing you had a chronic condition and you will need pain medication for the rest of your life, Wouldn't 12 hours be easier to take one than every 4 hours because you're getting this uncertain distribution? So this is a nice, even, stable amount. All the same opioid side effects can be anticipated. And again, we watch for constipation. All the other stuff goes away. Okay. Now, it's controlled release. And we used to have, actually, I should change that slide. We had to take the 200 milligram tablets off the market because the drug addicts who got hold of it, and the same with OxyContin, the thing is that it's not scored. So if you cut that thing, you don't know how much you're getting. You could get it all in one side. So if something's not scored, there's no control. They started chewing it and dying. So patients, and I had patients with severe cancer pain that needed that 200, it was taken off. So they had to swallow more pills because the drug addicts decided that was a great way to get high. Okay? So it releases it, let me just say this slowly, over 12 hours. Now, if the patient is doing well on the 20, but they have breakthrough pain, look at it for 2 days. You might want to add a little more to the long-acting to keep that even thing. But you always have a breakthrough pain dose to go with the long-acting agent. Now, with MS-Contin, you don't get, and less so with OxyContin, but you don't get any effect when you give it for 10 hours. So it really is not even. So you usually have to cover it a little bit with other tablets or other doses of morphine until you get to that magic moment, and then you can keep it on a 12-hour basis. Okay. All right. OxyContin, you've heard more than enough about that. It has a biphasic delivery system, so you do get a little more within the first 2 hours than you would with MS-Contin. But it, again, the plan is 12 hours, and then if they need a breakthrough dose regularly, you just add that to the 12-hour dose. Nice, even course of pain management. Now, fentanyl. There have been a lot of horrible things that have happened through misuse of this because people treat them like they're narcotic, like a nicotine patch or Transderm. It is the most powerful narcotic that we have, okay? It gives 72 hours of relief if you have, if you've had it prescribed appropriately. And it came in 25, 50, 75, and 100 mic patches. They now have a 12.5, which is more appropriate, I think, for a lot of people because it's too much in the 25. Now, when you put a fentanyl patch on a patient, you take a magic marker and you put the date and the time. All right? When you they're not going to get anything for 10 hours, so you have to give them something because they have to develop in the subcutaneous tissue a little depot. So it's etching in there, okay? And when that depot is full, then it slow releases to the general circulation. So that's the thing with fentanyl patches. You don't take them on and put them off. You have a subcutaneous depot filling up and then being released. But it takes about 8 to 10 hours. So you cover with something else before that, okay? Now it releases, and this is the difference. If you have a OxyContin or an MS-Contin, the dose that you have is being released over say, divided by 12. That's what you're getting. You're getting 25 mics every hour with the Duragesic. That's different, okay? They cannot be cut, and I've had doctors tell patients over the phone, cut it in half then. It happened to be the DA's mother, and so we arrived the next day. People really respond when you come with a DA. And we gave him a wonderful, professional presentation, and the guy was white all the way through. But we did it. And, to say that is crazy. Okay, now, let's say you have to get that patch off. Somebody's made a mistake. I had one case where post-operatively, patient's ready to go home. She said that wasn't really very helpful for pain. The new PA, 75 mics of fentanyl. You have to be using at least 18 milligrams of morphine a day to qualify for 25 mics. It's never used for acute pain or postoperative pain. It's a chronic pain. All it, and if you're getting the right dose and it's being done correctly, you're not going to get any of those things except constipation with every single narcotic. Okay, so you get it off, but how long has it been on? If it's 10 hours, what are you going to do? What's the reversal agent? Okay, supposing you gave Narcan. How long does Narcan last? 45 minutes. This is a 72-hour. They're in the ICU on a Narcan drip. Okay, so Narcan is great, but it doesn't last. Okay, so if you have to take it off, you record that, you monitor them. I mean, even if it wasn't as serious as what I just said, but don't let them go home. Keep them in the hospital and watch. It degrades down to 50, but you want to watch their respirations. It has a metabolite, but it's benign. Now, do not use soap or solvents to remove the gel when you're changing from one to the other because that interferes with absorption. So people have to know so much about the agents they use. Okay.
It increases the absorption?
Yeah, and you know what else does? A fever. Supposing the patient's temperature goes up. They really are, you get the temperature under control because you know they're going to be absorbing much more fentanyl. They don't sunbathe in it. Sucks it in faster, yeah. They don't sunbathe, go in a hot tub with it. You got to tell them heat is going to make it absorb, and they could overdose. You had a question?
Yeah, we told them because the reason they make such a big deal about disposing
Yeah.
patches and stuff, we were told like by the third day that the buildup of skin cells is so much under the patch that they're really not receiving the adequate dose by about day 3. Is that true?
72 hours. There's still stuff in there. So it's not completely eliminated because now you're going to apply a new patch and you don't want to wait the 10 hours, right? Remember, first time patch, you wait 10 hours until the depot is in the skin and it's absorbed and going into the general circulation. When you're ready to take this one off and put a new one on in a different place, I've had people think they should put them back. No, in a different place. There's enough in that original depot to give you a little edge to start. So there's still some in the skin, and there surely is some in that disposable patch. And again, with children and pets, we prefer they flush that down the toilet. If they throw it in the garbage, it's dangerous. If they have a temperature, get it under control. Never for post-op pain, never for outpatient surgery. Never 25 mics, above 25 mics on initiation of therapy, okay? Because remember, it's in the depot of the skin. You don't know. Remember, it's not an exact science. You know, I have seen a big guy, he's like 6'2", 250 pounds, desat on 5 milligrams of morphine. Who would have thought that happened? And this little old lady that's about my size is sucking it up like you can't believe, and nothing's happening. Now, what is that? So we can't say this is the dose for a person. You got to watch your patients when you're giving narcotics. Okay. Okay, there's another patch, Butrans. It's a 7-day. And I haven't seen it used yet. I know it just came out, so you have information on it. But here's the duration of Butrans would be 7 days versus Durgesic for 3 days. Butrans is partial mu agonist, where you get the full Monty with fentanyl. Okay, let's go to the next. Okay, PCA overview. The advantages you all know. It's you're getting a dose all the time. You need a little more. You press the button and you get a little more. You need a patient intelligent enough to do it. I mean, we've had patients in situations where they say, oh, I'm still in a lot of pain, and the visitor presses the button. You have to have the procedure in place that only the patient who's informed of what this is is doing it. If you need to have somebody else, like a companion with the patient, they have to go through a training thing, and it's by proxy, PCA by proxy. A nurse can give a bolus dose, providing it's set up. But generally, what we hope, it's a constant, small amount of PCA. Let's say then PT is going to come up, so they can give themselves a little bit before, half an hour before the PT starts. So it's a great way of doing it, but you need intelligent people. I got a call one time that a person, some of the calls were terrible, but some were funny. Can't get him under control. He's got a PCA of this, and he's screaming in pain, calling us stupid. I go up, and the guy's pressing the light cord. They put the wrong cord there, so he's not pressing. So you never know. Now, in PCA, okay, and the thing is that the patient feels they have control. It's a good thing. Now, in all of the legal cases where there have been serious things, it's been mostly, that's what the research indicates, it's been mostly errors in programming rather than a pump. Now, if there's a problem with a pump, you take it off the unit. You don't put it someplace so that somebody will say, oh, we need a PCA pump, and they use it. Because once you're relying on a pump, it better be working effectively, okay? So the programming errors really are coming up as the more common way of running into trouble. Okay. All right. Okay. Now, you don't have to get into this in detail. It will be different in your hospitals, but you look at the policy. What about the order sheet for PCA? How do you do it? You need the background dose, the PCA dose, and all of that stuff will be outlined. Okay. All right, then we have epidural analgesia, and it's very effective, but very uncommon because the nurses need a lot of training. And you use a minuscule dose of narcotic compared to what you'd be giving IV. It would be if you gave 30 orally, you'd be given 30 orally, 10 would be IV, and it would be like 1 epidurally. So it's quite different, and usually, next one. Okay, that's just a picture of the anatomy. Next one. Yeah, usually they put in a local anesthetic, and you've got to be careful with this because you've got to be aware of what the signs of having the thing come out of its proper place and the patient getting anesthetic effects, like they'll have a funny metallic taste in their mouth and it's tingling. You shut the thing off, okay? So I won't get into that because you're not using it and it's not commonly used, but you really have to know what you're doing. And with epidural morphine, it rises fast, so the first 24 hours you have your greatest risk of errors, but let's just move on with that. Just be aware that if you're ever around epidural analgesia, you've got to really know what you're doing. Now, because constipation is such a constant and terrible problem with patients who are on opioids, we have something on the market now to stop it. It's given subcutaneously. It's called Relista. It's given subcutaneously, but only really for people who are chronically on narcotics. Let's see. And you have this slide there that will tell you what it does. Next. Okay, let's see. Yeah, usually it's given subcutaneously every other day, but no more than 1 dose in 24 hours, all right? But it's very effective. Okay, there are invasive techniques. So if we're trying to get somebody's pain under control and our medications are not appropriate or not working, we can do nerve blocks. We can ablate a nerve with radio frequency or with cryo, where we'll freeze it off, so we can do those things. You can have a rhizotomy or a cordotomy. These are all efforts to interfere with the transmission of pain, but it's local. We can talk a little bit about Narcan. Now you know that it's 45 minutes, right? And it's a pure opioid antagonist. It's potent. Now there's an overshoot phenomenon you have to be cautious about. So if somebody's not breathing at all, shoot it all in. But most of the time, we pick it up early enough so that you don't have to do that. Because remember, when you shoot it all, when you give it to the patient, you've now wiped out their analgesia. So the best thing to do would be to dilute it in normal saline, stick the needle in the plunger, and just keep pushing it till you get the breathing that you want and back off. So they're breathing and they still have some narcotic on board. The overshoot phenomenon is really dangerous. You can have pulmonary edema, and it's just everybody gets really nervous. I like to see Narcan taped to the wall when a patient has a PCA. I like to see the syringe right on the wall so that you can do something right away. Okay. Now, let's talk about tolerance. We mentioned before that, no, I don't think we did. Okay. If you were taking an antibiotic, you had a chronic thing that you needed an antibiotic, and X dose was given, and it wasn't working anymore, what do you think they'd do? Increase the dose. You'd become tolerant. It is true of every medication, not just narcotics. So if you have a person who's been taking oxycodone for a year, and he says to you, or she says to you, I'm not getting as much effect from it, what I hate to hear is a nurse saying, I think he's getting to like his Percocet. No, this is tolerance. This is going to happen with any medication. Again, that's back to attitude. There's a scientific reason, and science should always trump attitude. Okay, so now one or two things have happened. Either what we have is degradation enzymes produced, or there's down regulation of the mu receptor. So what does that mean? That means if it takes 5 milligrams to get it turned on and it doesn't anymore, because it may need 10 milligrams to turn it on. So it's a scientific thing. Tolerance does not mean anything pejorative about the patient. Okay? Addiction is a totally different situation. You've got to be using stuff for reasons other than pain, and it's affecting your life in a negative way. Okay? Pretty clear what that is. And they should be treated. Now, in pain clinics all over, you have contracts. In the outpatient division, we had a contract. The patient had to sign a contract that he was going to get medication, and he was not to increase the dose without calling us. Supposing he was tolerant, we'd like to know that, or whatever. Or is disease progressing? We'll make that decision. That he's not to get medication from any other person, only from us, and that early renewals will never happen. Okay? Never. We will evaluate the patient even if it's in the middle of the night. We have to send them someplace to get evaluated, and they may truly need more. But unless that's done, they're not getting a renewal. Now, addiction is very different than pseudo-addiction. You will see a lot of comments about patient behavior that is pseudo-addiction. Now, it's either that the pain is uncontrolled, or they're afraid that it's going to be uncontrolled. So when we have pseudo-addiction, you'll have somebody saying, watching the clock, watch that, they're going to ring the bell. Guess who it is? Wants his whatever. A pain consultant will come up and evaluate it and find out if it's pseudo-addiction, that he's under-medicated anyway. So maybe his pain is 9, but if he hounds you and gets the medication, it goes to 7. That's bad pain management. So when we come up and meet this hostile group, who, look at this, and we changed the dose and had him under control, it was totally different. So be aware of attitudes and look at it. If he's on the button all the time, supposing he is an addict, we know how to deal with that, but it may be somebody who's truly under-medicated and is so tense about getting his medication on time. And sometimes we get some awful behaviors, like people who wait, taking a long time to get to that patient. And just think of what the experience might be. Okay, now, somebody came up with, this is, in their fear of medicating patients with narcotics that might be running into addiction. And Beta has Narcan in the capsule. It's an interesting thing. It has long-acting morphine, and it's surrounded by Narcan. If it's taken as directed, the Narcan passes through with no effect. If it's crushed or chewed, Narcan immediately is released, and they get nothing.
That's smart. That's
So you can see that we're trying to stay ahead of misuse. We're trying to help people. We want to get them comfortable. We want to get them better. You saw the harmful effects of unrelieved pain. We're trying to do that. But you're going to have people. We had somebody, I knew every trick in the book. And they'd come in and try to tell you it. After a while, it wasn't going to work. But you look at them and you say they have problems too. Imagine spending your whole life. Well, really, it's a full-time job to be a drug addict. Just think of it. Every 4 hours, you've got to get another dose. So you can't just get high and sit there for the afternoon. You're already looking who you're going to rob or what you're going to do. So it's a full-time thing. Too bad no one has put them on a better course or a healthier course. So we do help people like this, but we'd like them to stay away from our pain patients. Okay, when would you call, and there should be a pain nurse consultant in every facility. When would you call one? Addicted patients, like for example, somebody's doing heavy dose heroin and he's in a car accident. He needs pain medication. But what do you hear? Don't give him too much. This guy's on so much heroin. What's the first metabolite of heroin? Morphine sulfate. So he's not doing it for pain relief. Oftentimes they have injuries they don't even feel. So this person is going to need much more, much higher dose, not these little doses because he's a drug addict or she's a drug addict. End-stage disease. When somebody has a DNR and they're dying, and there's a dose of morphine, whatever it is, every 2 hours, and you hear a nurse saying his respirations are very slow. The order is every 2 hours, the man is dying. Okay? And it's the rule of double effect. Why are you giving it to him? You're giving it to relieve pain, not to kill him. So if he dies, he's dying anyway. If you're uncomfortable about it, discuss it with a colleague there, but make sure you give the medication. Complex pain syndromes, and there are some very rare, unusual ones. And actually, you hope to God you would never get reflex dystrophy. Complex reflex. It's neuropathic chaos. And it's so painful, and it can come from something as simple as a sprained ankle or a major injury. And people who don't know that that exists will blow the patient off as to have, I had somebody say, how could he possibly have that much pain? He hardly touched that thing. The guy had it, and there are certain signs and symptoms. That's when they need specialists. So if it's out of your field, if you feel like you can't do anything, that's the time to call the specialist. Sickle cell disease, definitely that you should call the nurse consultant. We had a system in the ED when they came in that we were notified immediately, and we got them, the oxygen, the IVs, and the medication, not Demerol. They used to use Demerol with them all the time. It's the worst thing. So we'd get them under control, get their pain managed, see how much damage occurred from the ischemia, treat them, and get them back to work or whatever. Cystic fibrosis, very, very painful for patients. So you call in the pain specialist then. So then what happens when the nurse may have to call in a super specialist too. And you can't say that a hospital doesn't have a pain service. If they do surgery, they have anesthesia. And you can always call anesthesia and say, we can't get this guy's pain under control. So there are things to be done. And if not done and there's a bad outcome, that's the question the attorney will be asking you. What did you do? Well, I didn't call. Well, who would help? You have an anesthesia department. So you just have to be aware that there's some things we know and we can do. We have to know our medications. We have to, really look them up and make sure that we're comfortable. If you think a dose is off, you talk up the chain of command, and do everything you can to make the patient as comfortable as possible within reason. But we know with chronic disease, it's going to be medication, it's going to be exercise, it's going to be nutrition, it's going to be multimodal. So if they just want medication, it takes a lot of effort on your part to show them that, no, we're not saying if you exercise you won't have pain. We're saying it's part of the equation. So if your pain is relieved to a 7 with this medication by adding these other things, you may get it down to a 4. So if you explain it that way, you usually have a more cooperative patient. I think that's it, is it?
Any other questions?